Hello everyone. So today we're going to be talking about asthma, and basically, like we all know, asthma is a chronic inflammatory disorder of the airways and is characterized by recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. So it's usually associated with airway hyperresponsiveness or hypersensitivity and reversible airflow blockage. So asthma basically affects people of all ages, and it is a major global health issue. So it usually results from a combination of genetic predisposition, like you can get it from your parents, and you can also get it from environmental factors too. Like it can come like during like the cold season, so it can come. So it usually has triggers, and these triggers can include allergens like dust, specific smell, infections too can trigger it, exercise can trigger it, and irritants like smoke and pollution can also trigger this asthma condition. So the signs and symptoms of asthma, like I said, recurrent episodes of wheezing, shortness of breath or dyspnea as it's also called, chest tightness, like feeling like an elephant is sitting on your chest, like chest tightness, coughing, which is usually worse at night or during the early hours of the morning, then prolonged expiration and increased mucus production. So for the clinical presentation of this asthma condition, patients usually present with episodic respiratory symptoms that are usually often triggered by allergens, exercise, or infections, like I said before. And symptoms may range from mild to severe, with life-threatening exacerbations that usually require emergency care. So when we're talking about the etiology of asthma, that is the cause of asthma, asthma is caused by a lot of different factors. The first one is genetic predisposition. If you have a family history of asthma, you are more likely to get asthma yourself. And then we have environmental allergens like pollen. So as I say, it depends on the weather, it depends on the time of the year. So pollen can trigger you to have asthma if you are allergic to it. Dust mites, mold. Then we have occupational exposure to, like exposure to chemicals, fumes, dust. Then also if you have like respiratory infections, like viral infections like rhinovirus, for example, that is also a cause. Then physical activity, we call this exercise induced bronchoconstriction. So this too is a factor when we're talking about the etiology of asthma. Then some air pollutants like smoke, exhaust from cars, strong odors, they are also part too. Then for the risk factors of asthma, like I said, when we're talking about when we were talking about this etiology, family history, for having a family where even if it's just one person, that is also a risk factor. So having a family history of asthma and a family history of allergies, then when you are constantly exposed to tobacco smoke, obesity too is a risk factor, because you are putting more pressure on your body to carry out the normal function the body is meant to do. So you are putting more pressure on your body, so it demands for more things. And living in urban areas with high pollution levels too is a risk factor. And respiratory infections, especially in early childhood, is also another risk factor. and like I said before, exposure to occupational irritants too. So that is it about the risk factors. So when we are talking about the next thing, that is the anatomy and the physiology. When we are talking about the anatomy and the physiology, so asthma primarily affects the bronchi and the bronchioles, and the normal airway is usually lined with smooth muscle and mucosa, and in asthma, airway inflammation occurs, and this leads to bronchoconstriction. Here in bronchoconstriction, we'll see smooth muscle tightening, and then we also see also with this airway inflammation, besides bronchoconstriction, we'll see airway hyperresponsiveness, that is exaggerated response to triggers like allergens, for example. And then we'll also see mucosal edema and mucosal hypersecretion, which will in turn lead to this obstruction. So just that airway inflammation leads to these three things: bronchoconstriction, airway hyperresponsiveness, and mucosal edema and mucosal hypersecretion. So when we're talking about the pathophysiology of asthma, first, inflammation occurs. So how does this inflammation occur? So first, the person is exposed to triggers like this, like maybe dust or smoke. This could be an allergen, a trigger, and this trigger activates the immune cells. That is, the immune cells like the mast cells, the eosinophils, and the T helper cells. And by activating these immune cells, it leads to the release of inflammatory mediators like histamine, leukotrienes, and prostaglandins. So after this inflammatory process happens, then we'll have bronchoconstriction, and basically in this bronchoconstriction, the smooth muscle contracts. So we see a smooth muscle contraction, and this leads to the narrowing of the airways, and this will in turn lead to wheezing and breathlessness. So this is what causes this wheezing and breathlessness that we see in asthmatic patients. So we have the inflammation, then the bronchoconstriction, then we have the airway remodeling. This is the third stage. So here we'll see how the chronic inflammation can lead to structural changes like thickening of the airway walls and fibrosis, and it can cause irreversible obstruction in severe cases. So this is what would happen in severe cases of asthma. We'll see airway remodeling. So that is it about the pathophysiology. Then we'll look at the diagnosis. So when it comes to diagnosing asthma, first we have to look at the clinical history, and we have to take a note of the clinical history and the physical examination. So when it comes to the clinical history, so when we're talking about the clinical history or the medical history, first a doctor will typically ask about like the symptoms you're having, wheezing, there are signs of wheezing, shortness of breath, chest tightness, coughing, especially at night or early in the morning. Then he also asks about the triggers, like what is causing these symptoms, like is it the allergens, what kind of allergens, and he will ask about your family history. So basically just the causes, things that can cause this, that can lead up to this asthma condition. Then he will also asks like the frequency, like how often do these symptoms occur, and do they interfere with your daily activities, do they interfere with your sleep and all that. And he will also look at the medication response, because you look at the medication response, like is there improvements with bronchodilators like salbutamol, for example. So that is for medical history. Then alongside medical history, we have physical examination. So the doctor will ask, like, or the doctor would check for like the wheezing, like it's usually like a high-pitched breathing sound, this wheezing, and then signs of allergies, like is there nasal congestion, is there eczema, and then is there, he also look at signs like of increased breathing effort, like are you having difficulty breathing. So so that is basically for the physical examination. Then after looking at the medical history and having a physical examination, then sometimes this test can be performed. They call it pulmonary functions test, and basically this test or spirometry is another name for it, and basically this test measures the airflow limitation and reversibility with bronchodilators. So it measures the forced expiratory volume in 1 second, and it also measures the forced vital capacity. So it measures these two parameters. And then another diagnosis that can be done too is peak expiratory flow rate, which monitors the airway obstruction. Then we also have something called bronchoprovocation tests, which is used for diagnosing exercise or allergen induced asthma. So for this bronchoprovocation test, I remember reading something on it, but I cannot really remember, but I think is someone would, like, it's used for diagnosing exercise induced asthma. I'm not really sure, but I think someone would be told to get on a treadmill, and then they would check. It's just something about a treadmill, but I'm not so sure about it. But I'll look it up. So those are basically the diagnosis of this asthma. From my recent knowledges, those are the diagnoses of asthma. So we also have something called differential diagnosis. So for differential diagnosis, it just has to do with the illnesses or the infections that can mimic the same signs of asthma, like chronic obstructive pulmonary disease, COPD. It can mimic the same symptoms as asthma. Then cardiac asthma too. Then we also have pulmonary embolism and vocal cord dysfunction. So these illnesses, they can give you similar, if not the same, signs and of asthma, but it's just left for you to like differentiate it, because they each have like a peculiar thing that differentiates them from each other. But at first, they usually have similar symptoms. So that's why it's better to, like, when you're doing the diagnosis, to not just rely on one, do like more than one diagnosis for you to know the particular illness, and not to just treat it blindly because of the similar symptoms in different illnesses. So now we'll talk about the management of this asthma condition. When it comes to management of asthma condition, so asthma treatment, it aims to achieve symptom control, prevent exacerbations and minimize adverse effects of therapy. So first, we'll look at the non-pharmacological management, because there's always a non-pharmacological management, and then we'll look at the pharmacological management of asthma. So for the non-pharmacological management, the first is trigger avoidance. Like, if you know you are triggered by something like an allergen, is just avoid it. Avoid if it's smoke that you're allergic to, avoid places with smoke. If it's cold, avoid cold. If it's a particular odor, just avoid. Sometimes it's easier said than done, actually, because if you are living in a rural area now, and most of the time you are exposed to particular smells, smoke, you can't just avoid it like that. But any way you can, trigger avoidance is very beneficial. Then also breathing exercises, like just doing breathing exercises every now and then is helpful too. Then weight loss, this is particular for obese patients, like that would help particularly for patients that have obesity. Then allergen immunotherapy, this is for allergic asthma, like asthma that is caused by allergy. So that is for non-pharmacological management. So when we're talking about the pharmacological management of asthma, so asthma medications, they are divided into two categories. And basically, the first one, we have the relievers, or we can call them the rescue medications. Then we have the controllers, or the maintenance medications. So the relievers, the rescue medications, they are used for quick relief. So they are mostly used in acute cases of asthma. Then for the controllers, they are used for long-term management of this asthma. After most of the time is after using this these rescue medications. So these controllers, they prevent exacerbations. They are used for long-term management. So when it comes to the drug class, we have the first class of drugs that we have for asthma. We have the short-acting beta-2 agonists, so which is also known as SABA. So here we have salbutamol or albuterol. Then we have terbutaline. So basically, how they work is they stimulate beta-2 receptors in the bronchi, which causes bronchodilation. So they are usually first line for acute attacks. So they are an example of rescue medications. This salbutamol, they are an example of the rescue medications that I talked about. Then we have long-acting beta-2 agonists, like salmeterol, formoterol, and basically they have prolonged beta-2 stimulation, and they also cause bronchodilation. So they are particularly known as maintenance medication. So they are there for long-term use. So they give maintenance therapy when we're talking about this asthma condition. So then we have inhaled corticosteroids like fluticasone, beclomethasone, budesonide. So they reduce airway inflammation, and they are first line in cases of persistent asthma. So they are first line in cases of persistent asthma. Okay, then we have oral corticosteroids. I just talked about inhaled corticosteroids, which are used for persistent asthma. So oral corticosteroids like prednisolone, methylprednisolone, so they provide systemic anti-inflammatory effects, and they are used in cases of severe exacerbations or poorly controlled asthma, which asthma that can not be controlled with, for example, inhaled corticosteroids. So we use these oral corticosteroids to give the systemic anti-inflammatory effect. Then leukotriene receptor antagonist. So like, for example, montelukast, zafirlukast, So they block leukotriene receptors and they reduce inflammation and bronchoconstriction. So like I said before, leukotriene is part of the mediators of inflammation together with histamine too. So this leukotriene receptor antagonist, by blocking these leukotriene receptors, they block these mediators, and this is to reduction in the inflammation and bronchoconstriction. So they are mostly used as an alternative for mild asthma or exercise-induced asthma. This is when we use them. Then we have methylxanthines like theophylline, aminophylline. So how these drugs work, they are known as phosphodiesterase inhibitors, and by inhibiting this phosphodiesterase, they cause bronchodilation, and these days they are rarely used because of their side effects. They are unwanted side effects, so they are rarely used. Then we have anticholinergics like anticholinergics or muscarinic antagonists. So like ipratropium bromide, tiotropium. Ipratropium bromide is short acting, while tiotropium is long acting. And like their name implies, they block acetylcholine mediated bronchoconstriction, and they are used in combination therapy. So they are usually combined with either short acting beta 2 agonist or long acting. So that is when we use them. And we also have biologic therapies like monoclonal antibodies like omalizumab, which targets specific immune pathways to reduce inflammation. So this particular drug, omalizumab, is an anti-immunoglobulin E. So it targets the specific immune pathways to reduce this inflammation, and is mostly used for severe allergy. It's mostly used for severe allergy or eosinophilic asthma. So it's used for, sorry, not severe allergy, it's used for severe allergic or eosinophilic asthma. That's when we use this, because we don't commonly use it. Like, it's not really commonly used. So when we're looking at the prognosis of this asthma, basically with proper treatment, asthma can be well controlled and patients can lead and live normal lives. But however, in severe cases of asthma, because asthma can be mild, can be moderate, can be severe. So when we are looking at the severe cases of asthma, or asthma that is poorly managed, it can lead to complications such as frequent hospitalization and respiratory failure and even death. So it's better for asthma patients to receive the proper treatment. So that's all.